This is a short summary of a presentation I did on exposure therapy in Budapest in 2019. We began by talking about the range of phobias, which is rather large, but interestingly, phobias have an evolutionary bias, which means people are generally more scared of spiders than they are of cars, and also we might be more scared of the dark than electricity, even though cars and electricity are far more dangerous than spiders and the dark. The phobia we're most concerned with here is kinesiophobia, which is the fear of pain due to movement. During successful exposure therapy, a new set of behaviours seems to be learned when reduction strategies or safety behaviours are avoided. Then we looked at what is anxiety, and it's really very similar to pain. Anxiety is an organism's response to the perception of threat. You don't actually need a threat, just the perception of one that affects our feelings, thoughts and behaviours. And this, of course, is rather like pain. Actual or perceived tissue damage can cause us to experience pain. And this is influenced by our thoughts, behaviours and by social factors as well, which brings us the biopsychosocial factors, which are key to our understanding of pain. When we experience anxiety and when we experience pain, the brain activates the sympathetic nervous system and triggers the fight, flight, or freeze response. And I've added freeze because often when we experience pain, we don't fight or flight, we tend to tense up and freeze, particularly if we're experiencing some lower back pain, for example. And with this comes a physiological response, such as an increased heart rate, increases in breathing and also nausea as well. There's also a cognitive shift of attention and an increased threat focus. We become hypervigilant of key areas of the body, and also behavior wise we engage in avoidance behavior and safety seeking behavior, such as further assessments from doctors and chiropractors, for example. So when it comes to exposure therapy, what is it and how can we implement exposure therapy treatment? This slide here neatly summarises what exposure therapy is. The patient must be presented with information that's incompatible with their maladaptive beliefs about danger and intolerability, and this information may be presented in a verbal format or visually, or of course through experience of exercise and manual therapy. Safety and avoidance behaviours must be eliminated, and new behaviours must be strengthened to help them generalise and endure. Now there's one problem with pure raw exposure therapy, and that's that there is no warm-up and no other strategies for reducing discomfort during the exposure. Because by creating the biggest mismatch between bad expectation and a positive outcome, you have the strongest learning experience. So if the goal of exposure is the expectation outcome mismatch, then the bigger the mismatch, the better. And unfortunately, in a therapeutic setting, this often doesn't work for us. What does work better for us is the combination of cognitive therapy with exposure therapy, which essentially makes up cognitive behavioral therapy. And this is because the cognitive element involves explanation and pain education, which really helps patients to understand what we're trying to achieve and also helps for the outcomes to be more durable during normal daily life. So at this point, it's important to recognise that pure exposure therapy would not allow the use of any prior therapeutic input or even any prior therapeutic explanations. However, using a more inclusive cognitive behavioural therapy approach allows us to use a range of management strategies, which would of course involve explanation, exercise and manual therapies as well. Now I'd like to suggest that there is possibly an issue with the idea of graded exposure therapy or grading any kind of exposure for the patient. And this is because grading exposure in physical rehabilitation unwittingly perpetuates the notion that pain is harmful because you avoid the larger pain exposures. Also, graded exposure can also mistakenly install the belief that pain relief or habituation needs to occur if exposure is deemed to be successful. And of course, this is not the case because part of what we're trying to do with cognitive behavioral therapy is to educate the patients to know that they can experience pain during movement, during exercise, and that this is acceptable in the longer term management of their condition. So grading exposure and focusing too much on pain relief may enhance the maintenance of fear of movement and fear of pain. So during my talk, I presented the idea that we need to rethink the graded element of exposure to change the message that we're giving our patient and to change the narrative regarding pain exposure. We can still give the tasks hierarchy, but the exposure to them does not need to be graded. And perhaps more of a menu approach would be a better way of using and presenting this type of treatment approach. In reality, we all use exposure therapy every day when we're treating patients as we move the patients into new movement ranges and make them feel safe and then break down their maladaptive expectancies. And then when we've broken down those maladaptive beliefs and proven to the patients that they can move more than they thought they could, then we start to move them towards more functional tasks, to engage in more leisure activity, to bring in social elements, and also to work towards personal goals as well. Another thing that the research indicates and that we need to be really aware of, and that's that fear generalizes, but its removal can be specific. And pain, again, can be the same here. So that's why we aim for functional exercises and movement and task variety, because research in back pain patients, for example, showed that exposure to physical movement did not generalize across a range of other movements. So that's why we really need to make sure that we add in lots of movement variety in order to make the pain relief and the improved movement more generalized and more durable in normal daily activity. When it comes to reducing or extinguishing kinesiophobia, we can begin with just imaginary exposure performance or imaginary movements, for example, because the brain really can't tell the difference between imagined movements and real movements if enough thought is given to their performance. We can then move on to meaningful movements, which involve lots of variety and also paying attention to the environment, perhaps initially making the environment one which is safe for the person to perform the movements, the exercises and the rehabilitation, and then we can manipulate the environment to create more challenging situations which help to broaden and build the exposure element, effectively making it more durable. It's important, of course, that we need to engage with pain education so that the patient can accept the pain during some of their exercises and that the pain is not something which is a barrier to them performing normal everyday tasks. And the patients also need to be mindful of what they're doing and to pay attention to their movements. And this is where we can bring in things such as sensory discrimination and paying attention to the way that they move in more of a finite manner rather than just counting reps and sets. And that then brings us to desirable difficulties, which is something that was introduced in the anxiety research in 1994 and is a method of actually making things a bit harder during exposure in order to make the exposure therapy more durable and also for it to have a broader reach during normal everyday activities. And desirable difficulties include things such as reducing any coping strategies for pain, such as reducing analgesia, for example, or any pain-related rituals that people may have, by implementing the exposure in a more random pattern, as we discussed, and not in just a graded fashion, and also by adding in some extra stimuli, which this could include the discrimination training or adding resistance, or of course making the environment more stressful by making it more relative to the patient's sport, more relative to their work, or perhaps introducing sounds which induce small levels of stress for the patient as well. Then there was also the element of surprise rather than exposures which are planned and the patient is aware of beforehand. Successful exposure therapy as part of cognitive behavioral therapy can be designed on an individual patient basis, using a psychological functional assessment to glean the information needed in order to customize a patient plan. And this consists of three overarching questions, which are: what are the fear of pain and movement cues? What are the feared consequences of exposure to any of these cues? And what safety-seeking behaviors does the patient engage in? You can see on the screen here some of the more specific information that we're looking to glean from our patients when we ask those three key questions. In practice, when working with patients, I like to use the 3 systems approach, and some examples of this are shown on the screen here, where I've recorded some of the real patient thoughts, behaviors, and the physical symptoms that have been explained to me over the years by patients, and then I've also given some typical explanations which I use to discuss these things with patients and to help educate them and to essentially help to remove barriers to them progressing to improving their movement and improving their function. Okay, thank you for listening. This brings us to the end of this summarized and abbreviated presentation, and just a few concluding thoughts before we finish. In summary, cognitive behavioral therapy with exposure elements will serve us better than pure exposure therapy alone. Exposure therapy doesn't have to be graded, and if we do grade it, it might increase the threat value of pain and increase the focus on pain relief. We can improve our exposure treatments by adding in pain education, creating meaningful movement plans, and adding in some of the desirable difficulties. The functional assessment and the 3 systems approach can be utilized to better understand our patients and to create more individualized patient programs. Thank you for listening, and please keep an eye on the Physio channel for more educational videos.